Thank you for joining us today. I am Paula Brack, the Executive Director at the Sarah House, and I am joined by Deb Green, the coordinator of our Sexual Assault Nurse Examiner program. We are presenting Responding to the Co-Occurrence of Domestic Violence and Sexual Assault. Today, our agenda will include who we are at the Sarah House and what our work involves, how we are funded, a general information about our SANE program, our memorandums of understanding with our local hospitals, co-occurrence of domestic violence and sexual assault, and ongoing services through the lens of ACRIDI, SADI, and EDI. Sarah House is a child advocacy center, an adult sex assault center. We also provide services, especially for victims of domestic violence that report strangulation. And we do a lot of work in our communities and in our schools on social change and identifying sex assault and appropriate response. Our Child Advocacy Center, we provide forensic interviewing of children between the ages of 3 and 18, forensic medical examinations, wellness examinations, family advocacy, and ongoing services. For our adult victims, we provide them the options that they have for reporting a sex assault. We provide them with forensic medical examinations, forensic experiential, trauma-informed forensic interviewing, and ongoing services. In domestic violence, often victims come to us for strangulation assessment. So our nurses are trained in that. And so they will come here, and while they're here, we provide them with emergency needs, emergency financial assistance, and then we refer them on to other programs that can provide ongoing services. Our service area is the 13th Judicial District. It includes 7 counties: Morgan, Logan, Yuma, Kit Carson, Phillips, Sedgwick, and Washington counties. Our service area is 11,400 square miles. It's very rural, probably around 82,000 people within this very remote and underserved community. In 2023, we saw 480 primary and secondary victims. 151 interviews were done. Of those, 144 were for children. 7 were FEDI adult interviews of sex assault victims and domestic violence victims. We had 21 adult sex assault exams and 30 child wellness examinations. All of our funding comes from grants, donations, and fundraising. As you can see from this slide, 86% of our funding comes from federal grants. 8% comes from state grants, 4% from foundations, and 2% come from donations and fundraising. We have 2 major fundraisers each year. One of our fundraisers is a prairie golf tournament, and the other fundraiser is a 5K run walk. The SANE program receives funding from VOCA, rural VAWA, and fundraising. The cases referred from law enforcement and for forensic examinations are paid by the reporting law enforcement agency at the rate of $600 per examination, plus mileage in some cases. It is a much lower cost than if the exam is done at a hospital.
Hello, my name is Deb Green. I am a sexual assault nurse examiner, or SANE nurse, here at Sarah House, and I am also the SANE coordinator here at Sarah House. We employ 2 nurses full-time here at Sarah House to help meet the needs of our clients that we serve. The SANE nurses at Sarah House have multiple responsibilities. Any child who comes to Sarah House for a forensic interview is offered a wellness exam. These exams are complete head-to-toe physical exams looking at all the body parts to make sure that their bodies are okay and to be able to reassure the child that their bodies are okay. So we're looking for any signs of acute trauma that might be on them, as well as any signs of trauma that has happened in the past, that they might have scars or other signs that something might have happened to them in the past. And then just being able to reassure the child that their bodies are okay is really a huge thing for a child who's been through a traumatic event. To know that they're okay, that they're going to be okay, just is very, very important to them, and helping them to be able to move on and heal. We also are part of the multidisciplinary team, or the MDT, and this is really important with the children, because we're able to be part of the team that is able to observe the interview as it's taking place, and so we're able to hear what the child is talking about and what they disclose during the interview. And so we don't have to ask them to repeat their story, and we don't have to ask them a lot of questions because we've already heard what they've disclosed. And so that's been a really important thing, I think, for us, so that we're not having to make these kids relive this and go through it more than one time, and that they don't have to constantly having to be repeating their story over and over again. We are able to do medical forensic exams on these kids if they disclose within the appropriate time frame. So for pediatric kids, it's within 3 days, 72 hours, that we can collect evidence for sexual assault exams. And so if we're able to be within that time frame, we will go ahead and with law enforcement, we will go ahead and collect evidence for those sexual assault exams and turn that evidence over to law enforcement for them to use for their investigative purposes. We're also a part of what's called the CARE Network. And the CARE Network is something that is a program that started with the Kemp Center in Denver with the Children's Hospital. Both of our nurses are Care Network providers. We received specialized training through the Care Network, through the Kemp Center Care Network, to be able to provide exams for children who have been physically abused, sexually abused, or neglected. And we're able to provide those exams after having received this training, and then we can take that information and upload it into a secure server, and our mentor, which is a child abuse specialist, child abuse pediatrician, will be able to review those cases with us and give us feedback as far as, did we get everything we needed to get? How do we need to do this better in the future? What kinds of things are we looking at? Did we do everything we needed to do? Do we need to get more studies? Are there medications we need to provide? Anything like that, any kind of feedback to help us to better serve this patient. And so we're able to kind of give them the benefits of having seen a specialist at Children's without having to physically go to Denver to see the specialist. So it's really been a very huge benefit for us being in a rural area and not having a lot of access to this pediatrician specialist to be able to do this and provide this service for our patients. We also see patients that are survivors of sexual assault and domestic violence. And so we have a nurse that's on call 24 hours a day, 7 days a week. We take turns taking call, and we respond to calls that we get for sexual assault or domestic violence cases. And we can go to where the patient is and do those exams that fall within the time frame to be able to collect evidence for those particular cases. And that being said, we have developed a mobile SANE program. Several years ago, we talked about this, and we realized that a lot of the reason that patients end up not getting the services they need is because they go to a hospital and they tell their story, and then they're told, well, we don't do that here, and so you have to go somewhere else. And so they have to get in their car, drive, an hour or 2 hours away, and then repeat the whole process over again. And a lot of times patients don't want to do that. And so they end up not getting the services that they need. So we decided that we needed to take the services to the patient. So we purchased all the equipment that we needed to be able to provide the service for the client. And so we serve the 7 counties that we talked about earlier, and we go to where the patient is, and we provide the services wherever they present. And then also strangulation is something that we're unfortunately seeing a rise in. We're seeing a lot more cases of strangulation, and so we're able to provide these exams as well for strangulation. I've done a lot of training on strangulation, and I also do a lot of training for law enforcement and other agencies that desire to have more education about strangulation, because it is such a severe, serious problem and can be so dangerous. And so I want to make sure that our first responders and people that are dealing with these clients understand how serious it is, and even though they might not have any external marks about that show that they've been strangled, they still can be at a very high risk and be very much in danger. And so I want to make sure that they're getting the care that they need. So we do those strangulation exams for patients that have had that unfortunate event happen to them. Staffing has been an area that has been a challenge in the past for us here. Some of the reasons for that is that there are very few seasoned SANE nurses in this area. We do have a few that have been through the program and been trained and have worked as a SANE nurse, but most of those kind of have been there, done that, don't want to do it again for whatever reason. And so I've tried talking with them, and most of them, either are retired or they're involved in other things, or they're going to school, or whatever, but their life doesn't put them in a situation where they want to take call and do that at this point. I've gone to doing a lot of recruiting. I've talked to the ER nurses, labor and delivery nurses, different places, within our district, to talk to people to see if I can get some interest. And people just aren't interested. And even if they do, then we have this whole challenge of growing our own nurses, because it takes a while to, the program is a 64-hour didactic program. And once they finish that, trying to give them the experiences they need, the exams that they can get experience and get comfortable with doing the exams. And then once they actually do get that, having them maintain competency is really a challenge. And so it has been very challenging. We do have the 2 nurses now, and that seems to work well for us. Based on how busy we are. We're not a super busy program because we are in this rural area, and so we're not like in a metropolitan area where we're seeing multiple cases a day. That wouldn't work if we had that. So we have to kind of look at, you have to look at where you are and what your needs are and how that's going to work for you. But for us, having 2 nurses and we share the responsibility of call, that works pretty well for us. So I think for each program, you have to look at how that's going to work for you and what kind of staffing you need and what your options are. Other things to think about with staffing is the call schedule and how that's going to work. Again, we aren't a super busy program because we are very rural, like we talked about. And so for us, what works for us is that we take a call a week at a time. And it's not like we get called out every day. And so we're not, constantly being disturbed every night, having calls and everything. So that works well for us. Again, if you're in a bigger area, in a metropolitan area, that's probably not going to work for you. But it works well for us, and so we take that whole week, and then we have a whole week that we're not on call, and it works really well for us. But for most, larger programs, you're not going to be able to do that. But you're going to have a lot more nurses to fill your call slots, and so it's give and take. And then when we set up this mobile program, we needed to really look at our call response time, because we'd love to be able to say that, we're going to respond within an hour of the time that you call us. But the reality is that some of the places that we're responding to are an hour and a half, 2 hours away. And so we have to be very realistic about that we are going to respond within a reasonable time, and that it's going to take us an hour and a half or 2 hours to get to you, and so give us a little bit of time to get our stuff together and get there. And so we don't really promise a response time when we talked with our agencies that we're responding to. We haven't really said we're going to respond with X amount of time. We've told them that we will respond within a reasonable amount of time, and that we will discuss that when we get the call, depending on what's going on. Because also, if we're in the office during the day and we're in the middle of doing an exam here, that has to take precedence over that. So there's a lot of ifs in there, and so we want to make sure that we're not promising something that we can't deliver. With the Mobile SANE program, we wanted to reach out to the hospitals in our district and come up with a memorandum of understanding with each facility that we could, to be able to send our nurses into the hospitals and for them to be able to practice as a SANE nurse in those facilities and provide the services to the patients and be able to work within the constraints of those facilities. And so in doing that, the first thing that we did is that we went in and met with the CNO or the CEO or the ED director, whoever was the most appropriate person to kind of get the ball rolling with this. And we talked with them about what we had to offer and what we could do for them, and the fact that this was a program that was not going to cost them any money at all. We were going to bring our own supplies with us. We were not going to use any of their supplies. We were going to bring everything with us that we needed. It was going to be our staff. We were going to pay for our staff to do this, and that basically what we needed from them was a room with a door that we could take the patient into to do the exam for privacy, and that we would, and just to have the time to be able to do the exam there. And we didn't really need any other, anything else other than if we needed to provide medications for the patient, then their nurses would provide those medications, because we don't have access to their medications. Other than that, we didn't really need anything from them, and they would be freed up. They wouldn't be tied up with that patient for the time that it took us to do those exams. And then following that initial visit, I would provide them with a draft MOU, just kind of lining out everything that we talked about, so that they would have an idea of what that looked like, as far as the legal terms and all of that kind of stuff. We would tour the emergency department and talk with the staff and talk about what was logistically possible. Did you have a room that was going to work well for us to be able to do the exams in? Little things like, do you have a room that has a GYN bed or exam table in? Because that would even be better. That's like the ultimate dream for us, because it makes it so much easier for us to do the genital assessment if we have that GYN bed or GYN gurney. So if you have that, that's great. If you don't, we can make do. But we talk about those kinds of things, that if you have that, that'd be great. If you have a room that's kind of away from everybody else, that's kind of nice, because the patient doesn't feel like they're having people walking by looking at them all the time, that kind of stuff. And so just little logistical things like that we can talk with the nurses about, answer their questions about what their responsibilities are going to be, and just kind of talking with them and getting some information and answering their questions. And then from there, just following up with emails and phone calls to make sure that we're answering any questions they might have, and helping to facilitate them to feel comfortable with the program, and hopefully then sign the MOU. Once the MOU is actually signed, then I go in and provide in-person training with the ED providers and nursing staff, talk with them about the services that we provide to them, what kinds of patients are we going to see, who do they need to call us for. We're going to see those sexual assaults, those domestic violence, those strangulation patients, and the fact that we see pediatric patients, we see adult patients, we see adolescents, we see elderly. We're going to see all those patients. If they can call us for any age of patient, we'll come and see them. How do they go about getting us to respond? How do they get a hold of us? And how do they activate that whole process so that they know who they need to call and how they need to get a hold of us and what they need to do. And then I talk to them about what the SANE exam entails so that they understand that when we're in there for 2 or 3 hours, why it's taking us so long, so that they're not constantly just sitting there going, I wish they'd hurry up, we need that room, that they're understanding that it does take some time and why it does take some time. And then I always take advantage when I have a captive audience of doing strangulation training, because I do feel it is so important, because it is something that is so very dangerous and so very lethal, and I want people to understand how serious it is. And so I've been doing a lot of education about strangulation, and so anytime I go in and provide this in-person training with the ED providers and nursing staff, I do the education on strangulation so that they know what to look for, what questions to ask, and what kind of testing needs to be done for a patient that has suffered a strangulation event, a non-fatal strangulation event. So when we first started this program for the mobile SANE, we wanted to get memorandum of understanding, and we started with the 2 that were kind of closest to our area. One was in Fort Morgan, one was in Brush. They were both in Morgan County, and we were able to get those MOUs signed. And then I just kind of, from there, we kind of branched out, went into Sterling to Logan County, got that one obtained, and then just kind of kept branching out to all the different facilities. This says we have currently 8 MOUs. We actually have 9 now, and there's only 1 facility left in our district that we don't have, and I'm still, that's still on my radar. We're still working on getting in touch with them and talking with them about doing an MOU as well with them. But we do currently have 9 MOUs that are active, and it's working really well, and we're able to go into these facilities. They welcome us. They are very happy to have us there. We've never had any issues with anybody, and it's just been a really great program. Sometimes it's taken a while to get, through all the red tape to get the MOU signed, but once we've gotten it done, everybody's been really happy with it, and we've been able to get into those facilities really easily. So how do we go about getting patients that we need to have seen? Any time we see a pediatric patient, they have to be referred to us through law enforcement or DHS. So up to the age of 18. So that means that if you have a teenager that comes in the ER and says they were sexually assaulted, then we still have to call law enforcement and or DHS because it's a mandatory report. But they can come in through the emergency room, and that's kind of the initial way that we see them, or they might come in, by calling our crisis line or whatever. But we still have to call law enforcement because it is a mandatory report up to the age of 18. Adult cases, we can get them through, they might call our crisis line for, either a sexual assault, domestic violence, or strangulation. And so we can receive those patients through there. They do have options as far as reporting, and so we want to make sure that we provide them with that information and let them know what their options for reporting are, so that we can give them those correct options and protect their privacy as much as they want to have that protected. They might go to the emergency department and request to be seen through the emergency department, and then those emergency departments will contact us, and then we'll come into the emergency department and do the exams. Again, we'll talk with them about their reporting options and make sure that we are meeting their needs there. Or they might contact law enforcement, and law enforcement will contact us and ask us to see the patient. And we can see them either at the emergency departments, or we can see them at one of our locations. We have offices in Fort Morgan, Sterling, and Yuma. So we have 3 different facilities that we can take patients to see them and do exams. So we can do whatever their preference is. If they come to us through the crisis line or through law enforcement, we can offer to see them at the emergency department or at one of our facilities. So what services do we provide? Again, the medical forensic exams to be able to provide the service of collecting evidence for law enforcement for the purpose of their investigation within the correct time frames. For pediatric patients, it's up to 72 hours or 3 days. For adult and adolescent patients, it's up to 120 to 168 or 5 to 7 days for that population. We do the domestic violence exams. We can do strangulation exams, sexual assault exams. With our care network, we can do the child physical abuse exams. We do child wellness exams for all of the kids that come in for forensic interviews. And we also do our forensic photography. Who knew that when we became nurses that we were going to one day end up being photographers? But we do a lot of photography and have had to get pretty good at taking photographs. That becomes a big part of what we do, because this is a lot of the evidence that we collect is the photographs that we take of injuries and different things. So that's a big part of what we do as well. We also do a lot of prevention, especially when we're doing those wellness exams. We will do a lot of education during that time frame. We'll talk with kids about the swimsuit lesson, which is a book that was written, and it's a really great way to teach them about parts of their body that no one should see or touch, the parts that are covered by their swimsuit. We talk to them about secrets and what are good secrets and bad secrets, that things that are a surprise are good secrets. We're going to have a birthday party for somebody and we want to keep that a secret. That's a good secret. That's a surprise. But bad secrets are things that, someone tells you that you're not supposed to tell anybody. So we talk about secrets and when it's okay to keep a secret. And we ask them to identify safe adults that they have in their life, so that if they have something that they're worried about or they're scared about or anything like that, that they have people in their life that they can go to that are safe adults that they can talk to about what's going on and what they need to do with that situation so that they can get help that they need.
Multidisciplinary teams are very important to the work that we do. We have 3 teams in the 13th district, one in Morgan, one in Logan, and one in Yuma County. These teams are made up of professionals from the Department of Human Services, law enforcement, medical, mental health, district attorney's office, and then members of our staff. We will review cases from the time they come in until they are closed within each of the offices of DHS, law enforcement, and the district attorney's office. The National Council Against Domestic Violence reported that 40 to 45% of individuals in an abusive relationship will also be sexually assaulted by their partner. It is also reported that 33% of sexual assaults are perpetrated by a current or former intimate partner. Reproductive coercion is a collection of behaviors that interfere with decision-making related to reproductive health. These behaviors are meant to maintain power and control. There are 3 forms, including pregnancy coercion, birth control, sabotage, and controlling the outcome of pregnancy. The overlap is prevalent. The exertion of power and control over another person is often very confusing for a victim that is in an intimate partner relationship and is unsure of what is normal sexual behavior, when the marriage condition is often pronounced through intimacy and giving in to the other. Sex assault may not be reported as part of the violence. It may take time through trauma-informed advocacy and therapy for a victim to realize, talk about, and report the sexual abuse in their relationship. Survivors experience higher levels of physical and psychological trauma, including PTSD, depression, and anxiety. The impact on survivors may include physical health, which is increased risk of injury, chronic pain, gastrointestinal disorders, and reproductive health issues. Mental health, higher rates of PTSD, depression, anxiety, and suicidal behavior. And there are social consequences: isolation from support networks, difficulty maintaining employment, and challenges in securing safe housing. Intervention and support may include integrated services, providing coordinated services that address both domestic violence and sexual assault, including counseling, legal assistance, and emergency housing. Training for professionals, educating healthcare providers, law enforcement, and human service workers to recognize and respond to the co-occurrence of these abuses. And community awareness, promoting public awareness campaigns to change cultural norms and reduce stigma. Sexual assault demonstration initiative guiding principles may include a framework within the office atmosphere and for the people we serve, incorporating an understanding of trauma and its effects, creating an inclusive and accessible environment for healing, understanding of the range of people's experiences, recognizing the centrality of culture that is relevant to the people and the communities we serve, and a commitment to social justice and human rights. Accessible, culturally responsive, and trauma-informed services have core principles including physical and emotional safety, hope and resilience, relationship and connection, and a survivor-defined approach. Oppression has a direct impact on survivors, both in how they experience trauma as well as what resources are available to them as they heal. 3 key things for advocates to keep in mind. Anti-oppression work first starts with ourselves. We all have biases we need to work through. It's easier to notice things out there that are problematic, but we first must start with ourselves. An advocate's work is to provide safe and supportive services for all survivors in a manner that allows for one to show up as their whole selves with all of their identities and their experiences. Advocates must practice awareness that because oppression exists in our society, options and experiences are not the same for each person. Advocacy should center the person's self-identity needs and trust the survivor as the best expert on their own experiences. Agencies have a responsibility to create inclusive and accessible environments and staff training that includes victim-centered trauma response and an understanding that there are lasting effects of trauma. Culturally responsive staff practices and organizational policies support a foundation for spaces that are rooted in equity and survivor strengths. The organizational culture should include social, emotional, relational, programmatic, and a physical setting where the work takes place, including interactions with colleagues and people accessing services and available resources that support the work. Organizational outcomes should include increased effectiveness of services and work with system and other non-system programs in the community at large, increased confidence in providing services, advocating in systems, and identifying sexual violence, shared responsibility for providing sexual assault services, clearer organizational identity, and as a provider of sexual assault services, new and revised policies and procedures.
Thank you for joining us today. If you would, please take a few moments and select the appropriate QR code and fill out the attached evaluation. We would really appreciate your input. Thank you so much.
Thank you for watching today, and watch for additional training videos. Please complete the attached survey and follow us on social media at sarahhouseco.org. Thank you.